Hello, everyone. Thank you for joining us here today. This is our speaker series for HSTP, which is the Healthcare System Transformation Project at the Rhode Island Commission on the Deaf and Hard of Hearing. This speaker series spotlights deaf and hard of hearing healthcare professionals. My name is Christine West, and I'm the project manager for HSTP. I'm happy to introduce Dr. Michael Argenyi, MD, MPH, MSW, and also former medical resident at UMass Boston Medical Center and is now doing a fellowship with North Carolina Hospital. Yes, Christine, that's the Wake Forest Baptist Hospital, or rather Medical Center. Perfect. Thank you so much for joining us today and welcome. Thank you. I'm happy to be here and thanks for inviting me. Firstly, I'd like to start with a little bit about you. I'd like to know your background, what influenced you to become a doctor, what kinds of experiences you had in your life that made you want to be a doctor. Maybe you could share a little bit about your personal journey and how you got into healthcare professions in the first place. Well, my story is really not that interesting. The way I got into medicine, I always tell people that I kind of fell into it. Well, what I should say first is that both of my parents are doctors. And I watched them as a kid growing up, and I thought, they're way too busy. They're never home. It just takes too long, and I heard their stories about becoming doctors. Both of them were immigrants, and their journey was long and difficult. Their medical education took a long time because they moved here from Hungary, and everything takes longer. It's a much bigger investment to become a doctor. They finished their training and they were already in their 30s. So I thought, no, this isn't for me. So as an undergrad, I decided to major in history. I'm always interested in things like how societies are formed, how their policies are made, and what effect they have on societies. Particularly, I was interested in HIV and AIDS, and I thought maybe I could study those issues. And I wanted to start by studying European history, which never happened. I did meet someone and started to get interested in the field of nursing. That sounded like something I could do, be a nursing assistant. And I did start out as a nurse's assistant at a hospital. And I started at a nursing home, and then I moved on to a hospital. And I worked at Seattle Children's Hospital. I first started out in the medical unit, and then I transferred to the emergency department, which I really enjoyed. And I thought, maybe I could actually become a nurse. So I took all the coursework necessary for nursing school. I was still pursuing history. And then I decided during my studies out there in Seattle, one of my teachers approached me at one point and said, you really ought to think about becoming a doctor. And I thought, really? Why? And the teacher said, well, you're smart and you really enjoy the puzzle aspect of medical school. You're not so much inclined to the caring part. And I thought, well, why not? So there were a couple of other things that were also I was mulling over. And I just thought about it and I thought, why not? I think I'll just do it. So I resigned from the nursing school, and I went ahead into pre-med, which meant that I had to take all the requirements: chemistry, biology, physics, organic chemistry. And I completed those courses and applied for medical school. And after a 1-year break between undergrad and applying for medical school, I tried to secure some interviews at different schools that had deaf people. And one of the schools I actually did interview at, and I thought, why don't I apply to 3 or 4 colleges at the same time, see what happens? And that's pretty typical. It's very difficult to get in. So I went to this interview at Creighton University, and I was accepted. It's interesting because during that interview, there was no interpreter. And I had pretty much grown up with cued speech and CART, so I really didn't know American Sign Language. Just a couple of signs, baby signs. But during the interview, there was no interpreter. So I used my speech and I listened. Actually, during college, I had gotten a cochlear implant, so I did have some understanding of English. It wasn't perfect, but I had some. So Creighton University, where I was accepted, sent me a letter, and it said, we're so happy to welcome you. There are a few technical standards. And I read those, and in fact, yes, there were some demands for behavior, for use of technology, some graduation requirements. I read through all of them, and they were acceptable. And one of them, it said that you have to be able to hear and interact with patients. And you have to be able to hear a heartbeat and the lungs and so forth. And I thought, well, I can manage that with technology and with the assistance of an interpreter. So I was more than happy to sign off on those requirements. I requested the technology I needed so that they could switch off. And this was a very long story that I'm going to make short, but the accommodations were really not what I needed. Medical school started in August, and there were no accommodations, just an FM system. So I hung in there for a couple of weeks. I really tried the best I could, but it was a struggle, and I kept asking for an interpreter or for CART, and they kept refusing to provide that. So I asked for some legal assistance. In fact, I retained a lawyer, and this took many years. This is a long story, but basically the court said, yes, I do need CART. Yes, I do need an interpreter. And by the time this decision came down, I was already facile in ASL because it took 5 years to complete the court case. And during those 5 years, I had been paying for my own CART. And then, like I said, I took a 3-year hiatus and came to Boston and fell in love with Boston. I got my MSW in Boston, and I actually went ahead and did some research in Boston during the whole time that the court case was pending. So finally, that was a long process, but once the judge did determine that, yes, in fact, I should actually be paid back for those accommodations, I started medical school in 2009. I put that on hold for a couple of years. And then that was suspended for 3 years. So I didn't actually return until 2014. And I completed my education in 2016. So yeah, this is Christine. That's a journey with a lot of barriers. Unbelievable. But going back to that lawsuit, you mentioned that there was a historically famous case, and that a lot of people cite that case. And I see this mentioned in a lot of the legal journals that I look at now. I wanted to ask you specifically, as a result of the lawsuit, there were really important results in terms of a couple of things: policy and also practice for medical education and practitioners, the idea of meaningful access, and also the idea of the importance of prior, universities usually dictated the type of accommodation that they're going to give you. But the result of that lawsuit was one of the first times where the importance of the respecting the deaf or the hard of hearing individuals' requested accommodations was raised. Would you be willing to talk about those two things? Because meaningful access for you and also how you apply your work as a doctor, both your own work and the accommodations that you need to use, and to the patients, the accommodations that they might need in order to have access or meaningful access. There's a respect for the individual's preferred accommodations. And I wonder if you could just talk about that a little bit. Sure. So not only because it's legally appropriate for medical school, but other situations as well. For example, and I'm not a lawyer, so do take my comments into consideration, but meaningful access, for example, that could include things like access to lectures in a lecture hall. They tend to be very dark, and there may be slides being shown. Could be anatomy or some other kind of course where the room is very dark and where an interpreter wouldn't be effective. Back in 2009, I wasn't a very good signer. I was still learning sign and learning how to read sign language, so that wouldn't have been meaningful access. But what I would try to do is look at the slide and then read the slide at the same time. I would try to listen and try to watch the interpreter. And I would miss way too much if I did that. That really wouldn't be meaningful access to me. So having CART was something that I could actually look at and then look at the screen, and that allowed me to follow along better because I could see the screen and the words on CART, and they remained on the screen so that I could read them and I could actually refer back to them. So then I could take my own notes. I know other people prefer to have a note taker, which is fine, but I just never did. I like to take my own notes. I didn't want to spend time reading their notes and then having that fit with my style. So I like looking and listening and then having CART for other situations. So it wouldn't be appropriate for me to have an interpreter. For a lot of hearing people, I think it's hard for them to understand how every situation is different. There's a lot of nuance involved. So when I try to explain it, like for example, if I went into the hospital to do rounds with other professionals, sometimes it would be a specific academic center or a teaching hospital like UMass. There could be 20 other people doing rounds with me. And in a situation like that, CART might work. I've worked with CART. It's not bad. But, it's another machine in the room, and you have to push it around with you, and sometimes it's not really easy to navigate the actual floor space and the hallways, going in and out of patients' rooms. So for a situation like that, I prefer interpreters because the interpreter can navigate the space better, and there's no machine that goes along with them. So it really depends what combination works best in which situation. And it also depends at the time on my language and my language proficiency, because I need to ask the interpreter who is really good with, for one who's really good with transliteration. Some interpreters are much better in ASL, but they're not very good with transliteration. And I really need the English vocabulary. And some interpreters are not very good at listening and then getting the vocabulary. So you have to be confident in your interpreter, and everyone has a different training background, different vocabulary. So an interpreter needs to listen to the medical vocabulary and understand it with proficiency. Maybe also there are some local differences, like names of towns or local experiences with accents. That's actually, those interpreters will be a better fit for someone like me. in terms of meaningful access. With the lawsuit, just to answer your question, I really wanted my access to be just like everyone else's, meaning that I would have access to everything, slides. And it's fine if I can read a slide, but let's say the doctor or the professor was explaining the slide. Well, reading the slide wouldn't be equal access. And also with my colleagues, I wanted to gather with them and be able to discuss relevant topics and the content. Thank you. So I'm going to shift a little bit now. And I want to ask you about deaf and hard of hearing individuals and the importance of having them involved. And also those practitioners who are deaf and hard of hearing, the benefits to the deaf and hard of hearing community to have healthcare professionals who are themselves deaf or hard of hearing. Also in healthcare profession, how can hearing people benefit by having a deaf or a hard of hearing medical practitioner? You know, you're a role model. So tell me a little bit more about that. Well, the last part is easy because a role model, I must say, this is a person who really supports you. And my journey was quite a bit longer. You know, I started socializing with deaf and hard of hearing people back in medical school, back in 2008. And now there are so many more people in the profession, and I have a lot more options. There was one doctor, Christopher Moreland, a deaf doctor in Texas. He had a cochlear implant, but he was also fluent in sign language, and he could speak. He had a designated interpreter with him, and he was a great role model for me. He's very successful. He had really great communication abilities, and he could advocate for himself and others and provide service to other deaf and hard of hearing people. So I can answer your question easily. He was the one person, when I think of my role model, I think of him. I want to, be him eventually. He's still very active with a long career ahead of him. So I look forward to continuing to watch where he goes and where I can learn. I can learn so much from him. There are others as well, but I would say he's my number one. That's wonderful. So in general, what are some of the benefits of seeing a deaf or hard of hearing healthcare professional? A doctor, a nurse. What are some of the benefits? Well, there are a number of benefits that I can remember the first time I told my father I wanted to become a doctor. And it's interesting because he was supportive. And I told him I was thinking about going into emergency medicine or something like that. I was naive. And my father said, as a deaf person, do you think you can do it? And I know that he had kind of an agenda there, and I thought about it. There were no ER doctors who were deaf or hard of hearing maybe, but no deaf doctors that I knew of. And I thought, well, maybe there will be some in the future, but there are none as of yet. And it is nice to have someone, a role model of some kind that you can emulate so that you're not actually reinventing the wheel, so to speak. And you can use those folks. They're examples. So when other people tell you, no, it's not possible, you can bring up their names. For example, there's another deaf doctor who has also had a lawsuit. And the judge basically said that the medical school had no case. And that's because we already had successful deaf and hard of hearing doctors. So the proof is evident. So the school really had no case. So, you can and I can. You slowly just have to break down the barriers. And it's not only in medicine, by the way. Other professions have barriers too. I think I know from talking to other professionals, it's hard for deaf people to be policemen, to be in the military, and some other specialties. I think it would be very tough for a deaf person. But slowly, barriers are being broken, and the opportunities are opening up for deaf people. So I think it's beneficial to have deaf people as healthcare professionals. I think a deaf person would prefer a provider with the same hearing status, to have a nurse or a doctor or a physician assistant that can relate to you. That's very positive. And I'd say one big project of mine that I've tried to develop is having content in ASL for medical terminology. So I know the Mass Commission on the Deaf and Hard of Hearing is soon going to be releasing a deaf and hard of hearing series with actors that has ASL for STDs and HIV healthcare. Oh, yeah, it's a plus. I'm looking forward to it. So now I'm going to narrow down to your specialty. You've worked with LGBTQ health, and I want to know where you got your interest. What drew you to that area? Sure, well, I'm gay myself, so I've always been interested. I came out pretty young, I was about 13 or 14, to a group of people, and ever since then, I've been out and proud. But I remember I had to educate my doctors about my own health. I wanted to learn about my body. I wanted to learn about sex and other things because growing up, in fact, recently, well, see, I came out in 2000, so that's relatively recent. And that was after Matthew Shepard's murder. And when HIV was still fairly new. And I was interested in studying medicine. I was a teenager at the time, but I couldn't apply all the information immediately. But I did think a lot about how does one remain healthy? I wanted to understand my friends and my community, so I was always interested in studying HIV. So I got interested in HIV and AIDS a long time ago, actually, even before I started medical school. And then with the lawsuit, and putting things on hold, when I got back to medical school, I wanted to think about what I'd like to do. I did consider emergency medicine, family medicine, pediatrics, and I decided to apply to family medicine for 1 year, and then I switched to preventative medicine. That was more focused on public health. And I was working in clinics, and that's really where I really developed my interest in HIV and STDs. In my 4th year of medical school, I worked in the emergency department, and I talked to someone there who said, "Hey, there's a deaf person in the other room. Do you want to see him?" And I said, "Well, sure, absolutely." So I went ahead and met with this deaf guy, and it was a really complicated case. The person himself was not educated about his own health care. ASL was his first language and his primary language. And the person identified as ex-gay, that they used to be gay and now they were straight. And I said, fine, that's okay. The person was also HIV positive. And the problem was, unfortunately, they had stopped their medication. So this person was talking about how it could or maybe the person wouldn't be at risk anymore, and if they stopped taking the medicine, this would be okay. And again, I was only in the emergency department very briefly, and HIV is not something we can cure, right? And now I wanted to impress upon this patient that reality, and for the first time I realized that people's lack of education about medical issues, especially HIV, if I hadn't been there that day, that person might have misunderstood the implications of stopping their medication. Because the person came in for back pain. They didn't come in for anything to do with HIV. But because I was there, I was able to have a conversation with him and was able to learn about his life. And I feel like, if I hadn't been there, I don't think the person would have come out himself. I mean, maybe with an interpreter there, but I don't know. I doubt it. So I can't say I was successful that day, but I can say that it was a learning experience that I'll never forget because, now I wonder, and I know, actually how it must be to be deaf and hard of hearing with very little education or exposure about HIV and very few resources that could even help you identify that you have it. I mean, very few resources to talk about being gay in the first place. So I really, really wanted to be able to teach people how to have safer sex, how to stop spreading HIV, which is not easy. So the following year, I did an internship with family medicine. And it's interesting because it just so happened I was on the OB ward. And I was responsible for working I was working under a senior doctor. And of course, this is all about babies being born and preterm labor and other possible issues and complications. And an ambulance pulled up to the hospital. Or actually, we got the call first, and it was a deaf woman who was going to be coming in, who was 8 months pregnant and had some bleeding. That's what we heard. So she got to the hospital, and we all got ready and gowned because we knew this was an emergency. And my supervising doctor and I went into the room, and lo and behold, she was not bleeding, and she was not pregnant. So we talked with her, and we did an ultrasound. She did have an IUD. She was definitely not pregnant. And I spoke with her a little bit more. And again, she had very, very little education. She was from another country. She was not bilingual in American Sign Language. And I tried very hard to help her understand what was going on. But because of the language level, it was really difficult to communicate. And also her knowledge, what I call her common fund of knowledge, the things that we all typically know about women's health, it was missing in her case. She just didn't have that knowledge. Fortunately, she was willing to be rescheduled, and she came back the next week into the clinic where we really sit down and talk. And that time I could explain to her about the IUD, and also there was a mass on one of her ovaries. We pretty much thought it was benign, but it was significant, and we did want to follow it and just check it every 6 months to keep an eye on it. So I explained to her about that, and she had no understanding of what an ovary was. And it makes me wonder, would she have even come to that appointment if I weren't deaf? And I don't think she would have, sadly. She did move away, and I actually never got to see her again. So again, just looking back on those couple of examples, I think it's really a resilient community, and resources are getting better. There's a lot more empowerment and education. Things are getting better. Medical education is getting better. And I think how the body functions, that knowledge is just not getting out there to the deaf community. So I'm more and more interested in figuring out how to combine the deaf and hard of hearing community with sex and health education and how the body functions. I think that's a really important connection to make. And also, as a gay person, I can say on a personal level, when I would try to date people, not so much in the past, but now I try to navigate situations where, disability sometimes will disempower somebody and it'll have an impact on a relationship. So if you're talking about the use of a condom and you're negotiating communication with your partner and you're both in bed and it's dark and you really need to turn the light on, or if your cochlear implant isn't in you, you need to turn the light on just for your own safety. You really need to negotiate these conversations. So I think it's important to have a leader to help people be better prepared to prevent HIV. Thank you for sharing those experiences. That leads me to my next question. You mentioned programs, resources, education, and really part of the Rhode Island Commission on the Deaf and Hard of Hearing's grant, the HSTP grant that we're working on, indicates that there's a need for deaf and hard of hearing community members to get access to healthcare providers, doctors, nurses, hospitals, but also to education. And so we're trying to figure out what a good starting point is for the state of Rhode Island for educating the deaf and hard of hearing community, and specifically with HIV, STDs, or even general health. How can people learn about their bodies? How can people get sex education? Should that start in high school or middle school? No, way before. Kindergarten? All the way through? I mean, what would that look like at each part of their education along the way? I would just love to hear your feedback. Well, it's really important, and particularly now because of COVID-19. I mean, this is a unique time. And we're switching to using these masks where maybe interpreters aren't there, but maybe they're online, so they're virtual. And the first and most important thing is to educate people about their rights and educate them about other possible technical accommodations, things that will fit their requirements, because we want to be safe and we want to stop the spread of COVID-19. But how to do that with a face mask? Is it better to go to the doctor's office? A lot of doctors, people are wary of going, and a lot of these offices are actually closed. So I would say patients as well as doctors don't want to catch the virus, and that's really significant. I believe really like sex education should start in elementary school. San Francisco, in their public school system, has a fantastic sex ed curriculum. And it starts with, I believe, first or second grade. It's very basic. It talks about gay men, lesbian women, that kind of stuff. Really basic anatomy, just so that you know the medical terminology. And it gets more and more advanced as the students get older. And we talk about deaf health research. Gallaudet University has found from their research that deaf people will go to social media for information, and rather than going to a doctor. And too often there are gaps, unfortunately, communication gaps. They'll go to their peers or social media, and that's not always the right place to go. But it doesn't mean you can't use social media, but it's important that you have trusted leaders, because we know the information isn't always right on social media. And you want to make sure that you're getting accurate content. So if you follow the right people, the right leaders in the community on social media, if there's a good vlog, and it should be a short vlog, if the people will really watch something, it's got to be an ASL, and it's got to be to the point. If the person in the vlog is a member of the community, a VIP, someone who is, I would just say, someone in the community who is well respected by the community. That's a really, really good advantage. And this person will have good content. They'll be able to fix the disparities and the misunderstandings and the misinformation, because they're trusted and people will understand them. It's hard to keep people's attention, and we really do need the educators to be in the schools for the deaf and those deaf people who are mainstreamed as well in public schools. The information should be a really good curriculum, and it should be translated into American Sign Language, and it should start early. I think, with the current situation, right now we're dealing with COVID-19. it's really best to educate the providers about different technologies. For example, I went to my audiology appointment, I don't know, it wasn't too long ago, maybe last month, and they didn't have a clear mask. They had a mask on, a gown on, they had gloves on, and this is an audiologist. I did okay, but I don't know. Other friends of mine who are deaf and hard of hearing or who've lost their hearing later in life, they go for a hearing test or maybe something pertaining to a cochlear implant, and the audiologists don't have clear masks. So it's really important to educate those service providers so that they're a better fit. Even with interpreters, it's really important because we do need to lip read while looking at sign. And we need to see the friendly faces, which you can't see with the standard mask. Yeah, it always helps to see the face. So in Massachusetts, they used to have a program for deaf and hard of hearing people who are HIV positive, and they had a case manager. But unfortunately, that program shut down because of funding. But I think it would be great if New England had some sort of a regional center to include Connecticut, Rhode Island, Maine, and so forth, all of New England. There could be people you could meet with, even virtually, so that you could be basically in person and have a large network that's connected to the HIV community. We really want to make sure that we connect with deaf and hard of hearing providers who are proficient in ASL. And I know there's a lot of confusion about how HIV and COVID are related, and that information is still very, very scant. There's just not a lot of coordination with the information. And there's not a lot of content in ASL, unfortunately. So who's going to provide that content? I don't know. Right, that's an important point with COVID-19. We're seeing a lot of information from the state departments of health, but the information is not accessible to deaf and hard of hearing people in ASL vlogs. We really need funding to provide them, but they have budgetary constraints and they don't often include this as line items in their budgets. It's tricky. So there really aren't very many vlogs, and that's sad. I will say that in Rhode Island so far, we've done a good job of providing information through ASL by making vlogs through the Commission on the Deaf and Hard of Hearing. I think they've done a fantastic job of providing information to the community. But I do agree with you about having a New England-wide program, because right now, each state is so siloed. There's just so much more that could be accomplished when we get together and have a regional perspective. So there's a lot of value to that. It makes a lot of sense. You mentioned data, and I wanted to tell you that one of the goals of HSTP is to collect data in general about health information pertaining to deaf and hard of hearing people. It's very scarce right now. So especially I'm thinking for the LGBT community, who are the deaf and hard of hearing? For the LGBT community who are deaf and hard of hearing. I'm wondering, what's your knowledge about the data available in terms of healthcare for deaf and hard of hearing people, specifically LGBT deaf and hard of hearing people? Can you talk about that a little bit? Yeah, there's very little research, but we do have some. The problem is there are two kinds of data. There are national surveys, and they don't ask about ASL compared to English, and they don't distinguish deaf and hard of hearing people. They just say hearing loss, and that's a big category. So the data isn't really easy to analyze because we don't know about whether a person has language deprivation and the impact of language deprivation on health versus other data that tends to be from Gallaudet or Rochester or other academic centers like Michigan, where they have a lot more work on deaf participation in research that tends to be more heavily ASL. So we have those ASL users in the data. When you compare them, they both show a disparity in healthcare. For example, things like health literacy. That tends to be very low, even if the person is college educated. And it tends to show some needs in the area of cardiovascular issues. There's much less understanding in the deaf and hard of hearing community. Also mental health. The data is mixed. In some cases, they say there's more depression and anxiety, and in others, other research shows that there's no difference. But to your point about the LG community, in terms of healthcare, the message is also mixed. They say that condoms are used less. And the data says that, in another study I recently read, it says that deaf and hard of hearing people know about prevention, but they use it as often as hearing people. There are also some studies that show HIV education and knowledge is much less than what hearing people get, and there's more complications with identity and intersectionality. So we do know that maybe prevention is used in both communities, but in general, basically this is from anecdotal information, when it comes down to a survey, who's going to be in the survey that tends to be fairly selective. Okay, so getting back to the first goal for our grant project, having to do with the data collection, you mentioned Gallaudet University, and in fact, we do have a contract with Gallaudet to develop the survey that we're planning to use with the deaf and hard of hearing community in Rhode Island. Well, that's good to hear. So it's been designed and translated, and then it will be ready to be dispersed on an online application with a consultant, and that consultant will be working with us, and there'll be training included so that it's done through the Deaf Center, which is more deaf-centric. Historically in Rhode Island, deaf people have participated in surveys to some degree, but I wonder if you could talk about getting people involved in participating in healthcare surveys. How can we convince deaf people and hard of hearing people that the information is important to us, and because that information is so scant, it could have an impact on other people if more information was provided, and this could be a nationwide impact. So how can we guide people to participate in surveys? They might think that they're not very important, but they can influence policy. Right, they are so important because they do have an influence on policy, and policy influences money. So a good survey is going to have both direct questions, like yes, no questions, not A, B, C, D, multiple choice. Well, how much is your income? How old are you? What's your gender identification? Or what's your sexual orientation? Actually, a good set of questions will include things like, leaving a blank, so that somebody could actually, in sign language, testify and tell a story, because that data informs policy. For example, a lot of surveys will talk about hearing loss, and that's it. About which languages you prefer, or do you prefer only one language? And some people who are deaf prefer an interpreter for their entire medical appointments in every medical setting. But, there are other people who really prefer to have things more private. But if you don't ask or get the story, then you don't understand why they want that privacy. If you know that an interpreter is needed for a medical situation, the hospital can show you the hospital documentation that says, I need an interpreter. And the hospital could say, we need to budget for that. because it's required by law. But sadly, a lot of times the hospital or the doctor will say, oh, we don't have the money. And so we'll have to figure out who and where those barriers are, where they live, so that we can sort it out, because there is lack of information. And we need things to be documented. That's really important. So we've got to survey deaf people and the medical field as well. It's okay for deaf people who use American Sign Language. And when they see their doctor, they may request an interpreter for those individuals, a doctor or any professional. So for those deaf people who do use ASL, and they go to visit their doctor, they request an interpreter. They may be hard of hearing. Maybe it could be a hard of hearing person who wants some other kind of technology. There's a lot of different technologies out there. So maybe people aren't really wanting to disclose that they're hard of hearing. It's difficult for them, and they may need accommodations. But what do you suggest for people who have difficulty identifying their communication needs? Like, you have a hard of hearing person, and they're not, they have a medical appointment, but they're not really sure what accommodations they need. They don't know what's out there. So we get situations like that. And how do you help people get access to doctors and other medical professionals? What suggestions do you have? That's interesting, because I'm hearing now, with COVID-19 and the masks are being used everywhere, people are trying to figure out that they have a hearing loss. They can't really tell because of the mask. They go over your ears and it covers your hearing aid. And actually, sometimes your hearing aids fall out. So you're missing a lot of information and don't realize it. So it's not even so much people with cochlear implants, but certainly for people with hearing aids, it's tricky. And so I'm hearing all these anecdotal stories of people with hearing loss and their experiences. And also what worked today may not work tomorrow, especially now with the masks on and the face shields. So there are a lot of different strategies. We could research. A friend of mine actually did some research. And it wasn't extensive, but we have a little bit of research on having a screening for hearing loss. The screenings could happen at different offices. And then you might have a range of audiological needs. Maybe you have earplug earphones and you listen for beeps, or maybe other sorts of testing. You could argue that it's important and actually worthwhile to set this screening up for doctors' offices or some other place. It's easy and it's very quick to do. A couple of minutes. I think also, suppose we identify someone who has a hearing loss. It appears that they're guessing at what I'm saying. Then what we might want to do is be prepared with a list of resources. There are so many people in my community who've had a hearing loss or are hard of hearing. They love the group HLAA, the Hearing Loss Association of America. They love that organization because it's such a friendly community and everyone there has similar experiences. And it's an older community, but when you can identify with someone like you, like someone who went to a deaf school or whatever, that's really nice. So older people with hearing loss do fine in certain situations and not in others. And it's good to hear their stories. And also there are a lot of webinars about technologies that you can use. You can find out how to advocate for yourself. And oftentimes you can actually get free samples of equipment to try out. So if an office or a hospital has a minimal staff, like one staff person and a mask with these see-through mouthpiece, you could try it and see if the person, let the person try it out. And you can ask how it's working for them. I think you really need to be open and non-judgmental, try out different things. test the waters a little bit. I think it's always good to test the waters. Thank you. Going back for a moment to your medical education. Colleges and universities that have medical schools, what sort of advice would you offer to them for deaf or hard of hearing students who want to become doctors? How can they make the environment and the educational experience friendly and meaningful? Because it's so important to include deaf and hard of hearing individuals in the professions with their programs. So what sort of advice would you give those medical schools? Just to clarify, Christine, do you mean the schools or the applicants? Well, actually both, the applicants and the schools. You're right, those are separate. So yeah, how do we make this an environment that's welcoming? Well, for applicants, there are a couple of things. There are some great resources. One can get in touch with the Association for Medical Professionals with Hearing Losses, and that group is right on Facebook. And it's on various apps and social media as well. So it's a great way to meet other people who've already done it, who've already been through it, and they've had that experience. Another thing that it can help you do is figure out which schools already have the experience with deaf students, because there are such a wide range of people, from having a little bit of hearing loss, maybe they're deaf in one ear, their accommodations might be fairly easy, and then you may have other deaf people who do not speak at all and use American Sign Language and prefer to use an interpreter. So it's not a one-size-fits-all situation. You have to get the student's advice, and you have to kind of know the tricks of the trade. Another thing I would mention is to do your research before. It doesn't mean you need to know every single thing, but you do need to know you're going to be learning a lot about what happens in medical school before you get in, because a lot of this is new information. Maybe you've worked in a hospital before, but maybe you haven't. Or maybe you've never run a code. Maybe, for example, you've never gone into an operating room and you've never assisted a surgeon before. So you're going to have a lot of new experiences. And of course, you can't know everything that's going to happen in medical school, but you need to come in looking ready. You need to come in looking like you can handle the situation, because when they're interviewing you, they may believe that a deaf person can handle this, but they're going to ask you how, and how that's going to work. So if you go in with confidence and examples of some great solutions to present in your interview, you can talk about technology, things like electrocardiogram machines, how you're going to read that, what models are the most accessible. Then the interview committee is going to trust you more, and they're going to believe you more. And I think it's going to be a much, much quicker connection. So medical school and physician assistant programs and, other schools as well, the best thing you can do is make the disability part of the conversation, because you should make it known that you like and want to apply as a person with a disability, and include disability-friendly language. So that's kind of a thing. It's disability-inclusive language, which means people are willing if people see that you're accepting accommodations. And if you're really going to be supplying this information, then people will feel like they won't be so shy about disclosing their disability. And that's really good advice. That's really great advice. Is there anything that you'd like to share, any last comments you'd like to make with our community? Anything that I haven't asked you, something you might want to add before we go ahead and wrap this up? I do have one other thing I would like to add. I've definitely, fought hard to get where I am. But at the same time, I have the privilege of being a white man. And I really hope to see many more black and brown and deaf people who use ASL join us and have their own success stories and have their own models and role models. And I want them to be part of our community. And, we're just so white. I also hope to see young people, black and brown people, men and women, deaf people who sign, hard of hearing people. I want to make sure that they follow their passion, especially if it's healthcare, because we need you. Boy, I agree with you 100%, Mike. And as an interpreter myself, an interpreter of color, I can second that. The idea of diversity. I mean, we need more interpreters, period, who are black, brown, etc. So I know where you're coming from. I think it's very important, and this should be a priority. And we are working on that. Both of our fields need to work in tandem to improve that situation. Well, thank you so much for joining us today. This is fantastic, and I know the community here will have learned so much from your talk. Thank you for your time, and I really, really enjoyed this conversation. Would it be okay if any of our community members wanted to contact you? That's fine with me. Okay, I'll be putting this information up at the end of this video then. I'll have your contact information. Thank you so much. Thank you, Christine. Take care and stay safe. You too.